and done multiple things for the world, the university, the British University associations. But most of my time now is spent in private practice. And so like Thomas, just wanted to mention the condition. So we have a really complex condition here where it is lots of things going on, and we know that it affects around about 1 to 3% of the population, which isn't a huge amount, but it is about 2/3 of the amount of elbow pain seen in general practice. And one of the most significant things with it is how it affects both your daily life, your occupational status, and also what you do in your leisure time. And the psychosocial aspect of it is really, really important. The important thing, or the interesting thing that we saw in Thomas's slide there as well, was that the management of this condition is that we really don't know what actually works and what works best. And about 30% of people still have problems a year after they start, even though they're having some form of treatment. That tells you how difficult this is. And Thomas had a much more filled out slide than this, but what we want to think about is obviously the structural changes within the tendon. We do know there's some sensitivity centrally, and we do also know that there are some motor control changes in there. We won't go over that again. So why would we choose Shockwave? Well, the simple answer here is that it's one of the options that we have. I'm hoping I'm going to shed some light on why you would use it and what it might actually help with. I think the fact that it's a non-invasive treatment that with what we're going to see is very few side effects lends itself to being an excellent adjunct if other things aren't working for you. So if we talk about what a shockwave is first, so it's characterized by a high energy acoustic wave, which is with a high pressure amplitude. So it's a rapid spike in pressure, which then drops quite rapidly as well in about less than 2 millisecond nanoseconds. And it passes through the skin and causes a biological response through mechanical construction, but also through some modulation of the nervous system as well. So quickly, we're just going to go through these. When we talk about the effects of shockwave, a lot of what we're talking about has been proven in animal studies and aren't directly related to humans. However, we can kind of see an inkling of what actually happens within the cells. And so they found that the endothelial tenocytes, fibroblasts, and osteoblast activities are upregulated after this. And it's through stimulation of lots of different enzymes that causes opening of the capillaries, which then brings in the kind of the pro-inflammatory and catabolic processes into the area. And we know that we kind of like to think of it as a healing instigator, as in you can restart an inflammatory reaction within the area where something has laid dormant for some time. These are usually very chronic conditions and have been managed for many times, and certainly the people that come and see me in clinic for shockwave, they've had multiple steroid injections along the way. We also know that there is some form of hyperstimulation analgesia, and the substance P and calcitonin, which causes a vasodilation and a reduction in prostaglandin and histamine. So we know that neurogenic inflammation that's caused by irritation of the elbow can be reduced. And also, interestingly, there was a study done in 2019 looking at central mechanisms. So this was an Achilles tendon study where they looked at shockwave for the Achilles tendon, and they looked at the pressure pain threshold of both the Achilles and at the lateral epicondyle. And they proved that the Achilles didn't actually change in pressure pain threshold, although they thought that might be to do with the equipment that they were measuring with, but certainly the pressure pain threshold in the elbow changed. So whether there is some form of analgesia, which is caused by central modulation, there is quite possible too. So this is a great quote from Cliff Eaton and Tim Watson in their latest book, and I would recommend it. Is that it's still not fully understood, but shockwave can provide pain relief, positively regulate inflammation, promote angiogenesis through these processes and even stimulate some form of stem cell activity. However, in terms of shockwave for tennis elbow, we're still lacking evidence to be absolutely certain. The other thing that we have noticed in some of the studies is that there is some form of decreased tendon organization after shockwave, and heavy loading should be proceeded with caution. And personally, I tend to go with just some easy isometrics while they're having the therapy before we then progress into heavier loading along the way. Sorry about that. So when we then look at how safe it is, so there are very few adverse effects noted in the tennis elbow, and most of the people that have it, so 21% of people here, they get the reddening of the skin. About 5% feel some form of pain, and 5% feel or have some form of hematoma in there as well, and some with some swelling, and then it gets less. But one thing I would note here is that the study is from 2002, and in the early studies that was done with shockwave, the protocols always called for the maximum tolerated pressure. And most people that come through this clinic, they usually tell me you can go more if you want, purely because they don't have a block. And like Thomas mentioned, people don't necessarily have a lot of I guess, proprioception around the elbow, but they do have this painful sensitization within the elbow, and therefore the kind of the swelling pain that they're feeling after treatment, I would say probably lower these days due to the methods that are used compared to what was done back in 2002. But it's the only study of its kind out there at the moment. So yeah, and the other research that's been presented, there's very little that describes any other effects apart from reddening of the skin and some mild pain, which is usually transient and goes away after about a day or so. So in terms of contraindications then, there are a few things that we can't do. So although we know it's a pretty safe treatment, we know that after steroid treatment, we have to be careful because there's a weakening of the collagen, and there has been tendon ruptures elsewhere in the body. Certainly if it hasn't been in the tennis elbow, in the common extensor tendon, then certainly it has been in an Achilles at one point. However, there are also other factors involved there. But we are often careful with the steroids, and we usually wait 4 to 6 weeks minimum before we would consider having shockwave after a steroid injection. The coagulation disorders and anticoagulant therapy, obviously hematoma is a risk factor, and so in these patients we want to be really, really careful. Rheumatological conditions, there's no real evidence to prove that shockwave can work, certainly in the elbow with rheumatological conditions, and it's not really an effective pain reliever in these problems. So antibiotic treatments, we have to be careful, and obviously due to the effect on tendons and degrading of tendons and the possible ruptures that are seen there. And obviously we wouldn't shockwave over an active tumor or certainly open skin either. But those are kind of the only thing that you can't use this treatment for. So then we're going to start looking into some of the research in lateral epicondylitis and tendinopathy, because most often than not, it's talking about that. And the early research, so we're talking like early 2000s, the results were very varied, and the results were pretty mixed, and the success rate is reported somewhere between 65 and 90%, depending on who you read. But there are some reasons for this, and there was a petition paper back in 2015 done by some of the top guys in what's called the ISMST, which is the International Society for Medical Shockwave Therapy. And they highlighted a few different issues, and one of them was that the different devices that are being used aren't really comparable with each other. So the results from one study to the next weren't really that transferable. So if you can imagine, a shockwave can be delivered in 3 different ways. One of them is electromagnetic, the other one's piezoelectric, and the other one's hydroelectric or hydraulic electric. And all 3 deliver a slightly different type of shockwave at different depths and can be used for different conditions. So some of these studies aren't transferable because of that. There's also a great variation in terms of the settings that are being used. So what kind of dosage people are using, and also what kind of protocol that are being used, how many treatments are being included, and also what we see, and what we'll see in some of the papers today, there's a great variation in terms of what they use as a control in terms of exercise or rehab, and there's a huge lack of rehab in general. And sometimes when rehab is mentioned, it's not really given much weight, and sometimes there's no rehab whatsoever. And in some of the studies, it's compared to physiotherapy, where TENS and ultrasound were the kind of controls. So, you know, we have to kind of exclude a lot of the research based on that. The second thing is that there is an inadequate loading in the rehab. So we know from Thomas's talk that we do need to load these things, and we need to have a comprehensive rehab program for these problems. And most of these studies are either not long enough or have the required program in there in conjunction with Shockwave to really show how effective it can be, or lack thereof. But in general, Shockwave has a large evidence base. I think the count is currently around about 9,000 papers for Shockwave in general. It's growing about 250 papers a year. From what I've seen on my latest search for lateral epicondylitis, there was 2 or 3 papers that have been published in 2020 already, and they're out there on PubMed, and people can look them up. But we're getting more and more of an evidence base, and the homogeneity of the protocols is getting better as we're going along. So there's 2 different types of Shockwave, or as I alluded to earlier, the high amplitude, high pressure, very rapid rise Shockwave, which you can see on the right-hand side, is what we would class as focused Shockwave. So that's a true Shockwave. What a lot of people have in their clinics is what's called a radial Shockwave, or radial pressure wave. And as you can see from the graph here that's being presented, that it has a very different rise rate and has a very different oscillation to what a Shockwave would have. So, and that doesn't mean that it's less effective. The Shockwave, the focused Shockwaves are around about 100 times as powerful as the radial pressure waves. But that just means that it can be used for different things. And the effectiveness of the 2 in lateral epicondylitis is very comparable. But they are different things. So when you look at the research, you need to know what that difference is. Again, here we've got a radial at the top and we've got a focused at the bottom. So radial is created by a ballistic missile that hits a transmitter at the end of the probe there, the blue bit. And that then sends this into the tissues, which then dissipates and spreads into the tissues. And we know that the effectiveness is around about 3 to 4 centimeters. And after that, it's very unlikely that you're going to hit anything and have a therapeutic effect. I think certainly in lateral epicondylitis, where all our structures are very, very superficial, radial works really, really well. Focused Shockwave, however, creates an impulse deeper into the tissues, and the effective rate is somewhere between 5 and 6 centimeters down into the skin. So what we have to do then to use that in lateral epicondylitis is actually put what's called a standoff on. So you can see the normal Shockwave as at the top, where the focal zone where you would hit the therapeutic depth is between 3.5 and 6.5 centimeters. But we can even have effects all the way down to 12.5 centimeters, which would be wholly inadequate for what we do in lateral epicondylitis. So we then go move down to standoff 1, which you can see it kind of puts a distance away from the Shockwave generator, and to the one at the bottom, which is the standoff 2, which is the one that we would normally use. Sorry, where our focal zone is somewhere between 1.5 or 0 to 3 centimeters down, and that then brings us into the range that we would need to treat lateral epicondylitis. The next thing to understand is that the pressure levels that are being used in the research and what we're actually needing to treat this condition. So in terms of Shockwave, it can be delivered in 3 different levels as such, and certainly as in the research. In practice, we can move within these levels. And high level in focus, which is a millijoule by millimeter squared that you can see upstairs, is considered above 0.25. And that's in a painful elbow, that will be completely intolerable anyway. But in some studies, that has been used. Low pressure is more than 0.1 millijoule and less than 0.25 millijoule, and nano is then less than 0.1 millijoule. That is comparable to the radial levels. These are only approximations, but it's as close as they can get them. That high level shockwave is over 5 bar. Certainly the machines that or I have in the clinic, which is the Storz machine, doesn't go beyond 5 bar. The low pressure, and you could argue that it's not clinically necessary either for certainly for tendinopathies. Low pressure is considered less than 5 bar, but more than 2 bar, and nano is anything below 2 bar. So at the moment, this means absolutely nothing unless you are a shockwave user and you can relate to these things. But it becomes important when we start looking at the different research papers. So the first one we're going to look at is this study by Falker and colleagues, which compared shockwave with an exercise versus exercise. Now, in terms of the exercise that was reported in here, the control that was being used and was used with the shockwave group 2 was concentric, eccentric, and isometrics, as well as stretching. So, and there was no kind of talk about what actually was done and how much was loaded. But seems though both groups had the same amount of exercise, and that this was done on a 3 weekly supervised exercise session. The shockwave group had 1 session of shockwave once a week for 3 weeks. So they received 2,000 pulses of this 0.06 millijoules, which is really low pressure, is in the nano range. So when I've mentioned before that traditionally in the early 2000s, it was the maximal pressure tolerated that was being used. This is the exact opposite. And what we can see from here is that, you know, the pressure pain threshold improved more in the shockwave group compared to the exercise group. The pain-free grip strength was improved compared to the control group. And the DASH functional questionnaire was also greater reduction in the shockwave group compared to the exercise group. And this was then followed up at 3 months, I believe. The next one I wanted to highlight was the shockwave and exercise versus sham and exercise. And the exercise here, I believe, was the one that I spoke about earlier, which included TENS and ultrasound. So we're going to discard that. And the sham here was the exact same treatment that was being used before, and the same application. So the radial shockwave or pressure wave through ultrasound gel onto the skin, but only with 0.1 bar pressure. So just about enough to make the machine do a clicking sound, but there would be very, very little pressure going through the skin and into the tissues. So what we found here was that the VAS, again, it dropped more in the shockwave group. We found the maximal grip strength was higher in the shockwave group, and the DASH scores were also lower in the shockwave group. And this was the same both at 6 weeks, 12 weeks, and 24 weeks. So we know that it can have an effect and continue to have an effect through several months after application. And again, this was 3 sessions or 1 week this was applied. Now, this is another study that used sham. And what was interesting about this one was that it found that it was no better than sham. And that kind of sparked my interest because I wanted to know a little bit more about it. And so I started looking into the protocols, and the sham was actually the same pressure, 1.8 bar, which is considered very low pressure, a bit like the ones I've been successful in other studies. But the applicator was held within the ultrasound gel and wasn't actually put onto the skin. So because it's an acoustic wave, there is some risk of contamination here, I believe, where the ultrasound gel would have transmitted some of the shockwaves through into the skin. But it's difficult to say. What they did find, however, was after 3 months, there was no difference between the two, but both of them improved. So it's, yeah, like I said, we need to understand this as well. But think there are some problems with the research methods here. The other thing that's interesting, and Thomas mentioned about the ultrasound and how non-specific it can be because of the high incidence of tendinopathy in even normal people. This is where it sometimes can be effective in ruling things out, and it might not be done straight off, but certainly further down the line if it's being resisted to treatment. So this compared the calcific tendinitis to a non-calcific in the tennis elbow, and it found there was no difference between groups there. And the only difference that they found was that in the calcific group, if there was a tendon tear together with the calcifications, you wouldn't respond to shockwave. So in this group, it would have been really beneficial to have had an ultrasound scan, and if there was a partial tear, you would then refer them on. They're much more likely to move on to surgery. And the other thing to note as well is that it was used 2,000 pulses for 4 weeks, and it was 1 time a week. And the energy range that they used is 0.06 to 0.12. So they were targeting the calcifications here. But what we know from things like shoulder calcifications, supraspinatus tendon calcifications, is that you need energy levels in the higher range, so above 0.25, to actually be able to create some form of a reabsorption of the calcifications. So whether the pressure there was just inadequate to show any difference between the two, I'm not sure, but it's really, really positive that we don't necessarily need to differentiate between the calcific and non-calcific. It works in both. And this is both done at 3 and 6 months. So we know that not only after 4 weeks, there's a continuation of improvements of symptoms up to 6 months. So then it comes to the question of high versus low dose. So some of them, like I said, are talking about really, really high doses. And in this study, the high dose was set at the upper or the lower limit of the upper range, which is 0.25 millijoules. And the low dose was set at the kind of the lower end of the low dose, which is 0.1 millijoule. And interestingly enough, every single outcome was better in the low dose one. And so that makes me think about the central sensitization that's kind of in the elbows and the pain responses that we tend to see in these problems, is that we may actually be better off going much, much lower and still getting a biological change in the tendon and in the area, both neuropathically and also physiologically in the tissues. And we don't necessarily need to obliterate the tissue, and that's really, really important. And we'll come back to that more in how we would treat it in the protocols. So, the interesting one here, we spoke about steroid injections with Thomas there, and we know that it's quite harmful for the tendons in the long term from the latest research, but often Shockwave gets compared to steroid injections, so I wanted to bring it in here. We also saw from the graph that it's the second most used second-line treatment for tennis elbow. So it is important to compare the two, I guess. And what we saw there is that the steroid injection was better in the early stages, and that's been proven in other papers too. But at 4 and 12 weeks, the Shockwave started to outperform the steroid injection, which is it's not surprising knowing what the steroid injections other research has shown. But then we're looking at surgery. So about 5 to 12% of people who have the lateral epicondylitis tendinopathies tend to progress into surgery. And so it's interesting to note in this study here, they did 1 session of Shockwave at a relatively high level, so higher end of the low dose, and only 1,500 pulses. And although there was a relatively low number of people in this study, they found that there wasn't really no difference in pressure pain, grip strength, or pain at rest at any one point in the study. However, surgery was slightly more successful at 12 months than Shockwave. But certainly, it could be a valuable alternative that should be looked at before you carry on onto surgery. And so, yeah, I'm going to bring it back to the fact that there was 1 session of Shockwave here compared to everybody else that's used 3. And it continued to improve from 12 weeks to 12 months. And that's really, really interesting. There were 3 people that were non-responders in this study. And out of those, they all 3 had a second session. And the second session, 2 of them got a good outcome and 1 failed treatment altogether. So when we then look at how we would treat it, Thomas mentioned multimodal treatment. It has to form part of this. And you know, the important bit for us, or for me, is how the wrist integrates with, the elbow tendons and forearm muscles integrate with the hand function, also in the shoulder and upper back function. So we know that there's a relationship between shoulder stability and rotator cuff and grip strength. And we also know that there is this common grip issue where you tend to go into wrist flexion more. And so those are the kind of the motor control elements to it. So when we then look at Shockwave, what we want to try to do is to try to lower the tone, and whether you call them trigger points or painful spots, it doesn't really matter. What we tend to see is that by using the radial shockwave, first of all, onto the muscle tissue, and for what I do in clinic is usually the forearm extensors. I sometimes evaluate the forearm flexors too. And I also look into deltoid and into the trapezius too, just because I know that they kind of functionally need to work together. And if there are any tight bits, then we tend to just put some shockwave on it. We know from the use of shockwave in neurological conditions that it can reduce spasticity and lower tone. And so we can use that to decrease tendon compression. A lot of people that come in here, that they have really, really tight forearm muscles due to the overuse. And this tends to really calm those muscles down really, and that maintains usually in at the second treatment. So what the other thing that we notice as well is that clinically this reduces the pain pressure threshold. So in clients that come and see me, they usually, after treating the muscle tissue, report around about 50% reduction in pain, pressure pain threshold. You know, but that could be attributed to factors like with Thomas's taping, where you can get a temporary response there, but it does tend to help them. It gives them a little bit more buy-in to the other treatment approaches that you're wanting to do, which is exercise and loading. So radial shockwave is ideal for more larger areas because the pressure kind of hits the skin and spreads outwards. You can cover bigger areas, and it's not so, you don't necessarily need to be very specific with it. So when we then treat the tendon, what's important here is obviously we can use both radial and focused shockwave. They both have evidence base and comparable results within this condition. But we know radial shockwave is less powerful, and so usually we need more pulses to stimulate the effects that we're looking for. And normally we would do 2,000 pulses at insertion, and then we also know that there is this hypervascular area around about 3 centimeters down from the insertion, which often takes a lot of biomechanical load, which also tends to be a very painful spot in these kind of problems. So we try to target both of them. And in terms of the Storz shockwave, that we have different transmitters, and you know, from the S15, which has actually got a plastic tip, which is really, really gentle onto the lateral epicondyle, the C15, which is even a little bit more, but less irritation on the skin, and then the R15 is the kind of the standard applicator that most machines come with. The energy density that we use on the elbow there is usually 1.8 to 2.2 bars, so in the lower end of the low dose and into the nano spectrum. When we're treating as well, it's really, really important for us to not create too much pain. So we don't want to sensitize the area even more. So we want to try to keep it under control. And what we tend to do is to ask the patients to report to us a VAS score during treatment. And we don't really want that to go above 3 to 4 out of 10. That's quite tolerable. They can stay relaxed during the treatment, and we don't get any or less adverse effects compared to what the previous studies have shown. So in terms of focus shockwave, we need less pulses. It's much more powerful in its shock. We use standoff too, like we mentioned in the picture earlier. And we start off usually with a very low energy density. And again, we gauge the patient's comfort. And usually as the treatment progresses, we can then increase the amount of pressure that goes on. But very rarely do we go over 0.12 millijoules, which is in the lower end again of the low dose. So to try to kind of conclude a little bit what we talked about, we know that shockwave is a safe and effective treatment option for this condition. It has very little adverse effects and certainly none that are serious. In terms of the effects and what we know about the basic research of it so far, is that we need to see it as a healing accelerant as well as a pain reliever. And really important, it's not a standalone modality. If anybody's using shockwave as a standalone modality, they're leaving so much on the table. There is a lengthy rehab that's needed for this, and like Thomas said, 12 weeks, and a lot of that is to do with the collagen synthesis. The collagen synthesis takes about 12 weeks in tendons, so to actually have a structural change in there, it needs continuous and gradual and progressive loading. When should you use it? Well, it's kind of seen upon as a treatment that you do once exercise has failed. I see it as a safe treatment that can have a positive effect on relieving pain and also potentially have this healing accelerant effect. So the way I tend to look at it is like I'm bringing the building blocks into the area of treatment, and then I load it to actually use those building blocks and generate a stronger reaction to that. But in general, the recommendations are it should only be used in recalcitrant issues, and I think that's a really great way to start. And once you get comfortable with the modality, you can certainly try it. What we do know is that they don't tend to respond very well in the reactive phase. So if you have something that's really acute, that's just come on, we know that it has very little role in there. It doesn't really help with pain, and it certainly doesn't speed up the condition, if you like. The dosages that we mentioned, okay, so energy density optimal seems to be the low dose, and at the lower end more than the higher end, both for radial and for focus. And pulse rates, the frequency in terms of hertz, there's no real difference that's been found. The traditional protocols for doing the insertions is around about 10 hertz. And when we're treating muscle tissue, and certainly if it's really, really hypersensitive, you can go higher up in the hertz and you'll generate less pain on the skin when you use them. And with that, I'd say thank you for listening to me. I hope you found it interesting a little bit about what Shockwave can do. Like I said, it forms part of the overall management of tennis elbow, and it's certainly not something that should be used on its own. I'll pass that over to Martin, and I'll be happy to answer any questions after that.
Yeah. Thank you, Ovi. That was good to improve the understanding on the use of shockwave in tennis elbow. So due to the time shortage, I got like 3 minutes. So I think we'll quickly go to questions. So if, Binoy, are you happy to go through the questions with
I think
Thomas first and then Ovi next? We can't answer all the questions, sorry, because of the time factor. We'll cover as much as we can.
So Thomas, is regarding the MWM. So there's a practical query on how long does the patient grip for when they're doing as their part of their self MWM at home?
It's a great question, and I can only bring it down to the individualization of treatment. So I use the self-mobilization with movement to engage patients in their self-management programs. So really, what I want them to do is to load up with the self-MWM in that pain-free range for those patients who need reduced pain with their exercise. So really, if you can reduce the pain-free grip strength, it may take, 10 repetitions, it may take 2 repetitions. But the important thing is, for those patients who need reduced pain, it reduces their pain, then they go on to load up.
Yeah, thanks. And also, I think this question regarding the efficacy and the mechanism. We know that mulligan MWM works. Is it the joint or the muscle? working.
Yes, is this a question from David Poulter?
Yeah, from Minnesota.
Yes, we've had a celebrity in attendance. Yeah. I think that's a great question. If you were to ask Brian Mulligan, he would say it's definitely a positional fault in the joint. If you were to ask Bill Vicenzino, he would say it's definitely a neurophysiological response. If you were to ask me, I'd diplomatically say I respect Brian's innovation and I respect Bill's reasoning.
Yeah. So I guess we still don't know. And about the question on the diagnosis, sometimes we can miss the entrapment, like the posterior interosseous nerve. So from your experience, wide experience, how is that different from your normal tennis elbow? If you have a pin involvement, how do you get the pain? Is it more distal? Do you have pins and needles, or is it a bit more different?
Yeah, so it's just